not know what is this. Is it visible now?
Now it is. Yes, it is.
It should be visible. Right. So welcome this evening show for PGNAR, and this evening we have got Dr. Manjunath Shenoy with us, a very famous personality. Dr. Manjunath Shenoy will be formally introduced by Dr. U.S. Agarwal and Dr. Lalit and these things. So we give you a virtual bouquet, Dr. Manjunath. So please accept a virtual bouquet with.
Thank you, sir. Thank you, sir.
Right.
And thanks for covering my head.
that is our Rajasthani specialty. That's our Rajasthani.
I love that. Yes, sir.
Right. So let me. तो मैं वो बीच में क्या है कई बार वो जो वंदना जो है ना वो हो जाती है तो मैंने देखा इसको आज बाहर से ही चलाते हैं लेटेस्ट. So before that, let Dr. US, can you please, Dr. US Agarwal?
Still, time still, sir, 6-7 minutes.
Doesn't matter. We start it and this is recorded, so we can, with the permission of Dr. Manjunath, we can put it on the YouTube. Right. Dr. US.
Participant. You can wait, I think.
No issue. Listen, what I am telling that we will be putting it up on the YouTube, so people will enjoy it later on also. So let it be comfortably doing it, right? No issue. Or if you want, we can wait for a minute or two.
There are very few participants right now.
Right now there are very few participants. Let everybody be introduced properly to Dr. Manjunath.
So let me have that Vandana. Is it audible? Is it audible?
Yes, sir.
Huh? Well, that was our evening prayer, and Dr. US, kindly introduce.
Good evening, sir. Am I audible?
Oh,
Yes,
yes,
sir.
very much.
Yes, yes.
So, good evening, everybody. It is my proud privilege and pleasure to introduce Dr. Manjunath Shenoy, who is at present Professor and Head, Department of Dermatology, Jnp Medical College, Bangalore, Karnataka. He is a well-known dermatologist among the IDBL members, and he is a regular faculty and has taken many lectures, has worked as panelist, moderator, quiz master, debater at the state level conferences, national conferences, and in the international CMEs. He has to his credit 73 publications in peer-reviewed journals, and he has more and a special interest in the dermatomycology. He has written more than 10 papers in dermatomycology and has written a chapter in the IDBL textbook of dermatology on the superficial mycosis in dermatology, and also he is convener of the reconstructed dermatophytosis in the SIG, IDBL. He has organized a conference of on the dermatophyte in 2018, and as a organizer, he has held many important key positions in organizing many conferences, including Dermacon 2015, Cuticon Karnataka branch 2017, Dermacon 2019, Derma Advanced 2016 as organizing secretary, Derma Basics 2018 as organizing chairperson, and Dermatophyte, as I told that he has a special interest in dermatology, dermatophytosis in 2017 as organizing chairman. He has held very important positions in the Karnataka state branch, including honorary secretary and president of the IDBL Karnataka branch. So it will be very interesting today to listen from Dr. Manjunath about the prospects of the therapy in psoriasis. And I request Dr. Dinesh Mathur, looking at his interest in dermatophytosis, let us have another lecture from him on the dermatophytosis if everybody is interested.
Sure, we'll be having a sort of I thought that we will have some panel discussion. One, he was also interested. This our DG Saple. He said, and Dr. Agrawal himself is doing some lot of work. Even I have got a lot of most of us we have got. It's a very this thing. So Manjunath, we can have a in that next month when DG Saple we can arrange it as a panel discussion.
Wonderful.
I request those people, those who are on mobile, please they can switch off their audio. Sorry, video and audio both, because many a times either it is seen like the moving fan on the this thing or some objectionable posture and all these things. It distracts the attention of the speaker. So my humble request to all people, those who are on the mobile, so do please shut off their video part also. So they will be comfortably seeing it. So Manjunath, can you please share your screen? I'll just
Yes, sir. Allow me to do that, sir.
right, please. Right. Please, now it is open for that. Right.
Can you see my
Oh,
screen, sir?
yes. Very well. So now all screen is yours, and another 1 hour it's all with you. And this will be a recorded this thing version. It can be uploaded on the YouTube later on.
Yes, sir. Sure, sir. Sure. So may I go ahead with my lecture, sir?
Please, you start.
Yes, sir. Yeah. So at the outset, I shall thank one of the most versatile personalities of IDWL and dermatology India, Dr. Dinesh Mathur, for giving me this opportunity. I take it as a big privilege to be here and amongst the best of the academicians of India and delivering this lecture. As rightly mentioned by US sir during my introduction, that I have a special interest in dermatophytes. But the thing is, I thought, for a while, let me also venture into other fields where I have got some interest, and one of those fields is psoriasis, and this is also very dear to me, and hence I chose to talk on this current and future perspectives in psoriasis therapy. Also, greetings from Mangalore to Dr. Lalit Gupta and many other senior faculty. I can't mention some of them. I could see Madam Srilata Trasi, Dr. Raghunath Reddy, and many others. I could see them. Thank you very much for being with me in this evening amongst your busy schedules. I'm sure you must be extremely busy and you must be tired with your practice, and but still you've been here. That's a great privilege I have today. And when it comes to psoriasis, we know psoriasis is a disease which is a chronic inflammatory disease, and one disease which can be considered as one of the best model for studying a lot of therapies, not just related to psoriasis. A number of therapies, may it be an adverse effect of a drug like a topical steroid or a cyclosporine or acitretin, or you take any drug, topical or systemic. This is probably the best model because it is a very visible disease. You have a plaque here, erythema is there, scaling is there, and you have beautiful scales to assess them. It may be a physician's global assessment scale, or it could be many other scales, or PASI. We have so many. So assessment is also beautiful by thanks to a lot of scientific academicians who have brought up this, and that's why psoriasis is one of the diseases is very dear to dermatologists, but unfortunately it's not dear to the patients because of the quality of life issues that it poses. We all know, disease like psoriasis or many dermatological diseases, including something like vitiligo and all, they have an extremely bad quality of life in afflicted patients, and it's as bad as cancer or coronary artery disease comparable to them. So with this little bit of introduction, I would get into some of the basic aspects of psoriasis therapy. We all know that psoriasis can manifest in various phenotypes. It could be a chronic plaque or a psoriasis vulgaris. We have erythrodermic variety where it involves near total body surface area with erythema and scaling. There is a pustular psoriasis. Then we have regional psoriasis that involves only the scalp, only the nails. Sometimes only a small portion of the skin. Sometimes we need to search for those lesions, and that's how the disease can manifest. It has got a various phenotype, and it can be important differential diagnosis for many other conditions, including serious diseases like cutaneous T-cell lymphoma or mycosis fungoides. So it has got so much phenotype because of which it can resemble a lot of diseases. And among the various phenotypes that we know, the best and the most common is chronic plaque type, or even we can call it as a psoriasis vulgaris, is probably accounts for over 80% of all cases. And this is where our most of the therapeutic armamentarium and the inventions are directed towards, and they are extrapolated into the other phenotypes of psoriasis. So we have the most common form of therapy in psoriasis, like almost every patient that receives is a topical treatment. We have these emollients, glucocorticoids, vitamin D3 analogs. Then we have second lines like dietranol, tazarotene, tar. Indeed, dietranol, tar used to be probably the first line therapy, say about 2 decades ago, but they are hardly used nowadays. We are using them when other drugs are exhausted, or we are tired of using them, or patients shows some of the adverse events. And when it comes to the next form of therapy is phototherapy. Phototherapy can be delivered in various means. It can be PUA, the conventional one, the NBUEB, relatively new one, not very new. It's over 2 decades now. And we have off late the excimer light, which can also be effective in psoriasis. Then comes the systemic therapy. So where do we use a systemic therapy? It's generally considered a moderate to severe disease. Moderate to severe means over 10% of the body surface area. What is to be noticed here, PASI is not a major issue here. PASI is more for, it's a research tool rather than a true clinical tool. It's a BSA which determines when one should give a systemic therapy. So it's 10% is the usual dictum, but that's not a rule. So we sometimes manage a patient with a very extensive disease also with just topical for various reasons. And at the same time, we also use systemic therapy for somebody with less than 10%, maybe 5% or even less. when it matters to the patient, when the quality of life is one of the very important determinant, if the QOL score is more than 10, less than 10, then once again it qualifies to be a moderate to severe disease, or once you can consider for a systemic therapy. So it is not just the BSA, not just the PGA, the physical global assessment, or the PASI. Even the QOL is very important. For example, somebody with a very severe scalp disease can have a very bad quality of life, or he has a very severe palmoplantar psoriasis, which can interfere in his day-to-day work. Once again, we use systemic therapies. The old conventional therapies like methotrexate, acitretin are still one of the mainstay in the treatment. We often use cyclosporine in such cases where there is a severe exacerbation. We want to give a quick relief to the patient as something like a bullet. We can use cyclosporine, and then we can probably switch over to other forms of therapy. We still use, some of us use hydroxyurea. I have used it, but not very happy. But sulfasalazine, thiaguanine, I think these are all almost they have become now almost history. But what of late what we are using is what is called the biologics. Biologicals are basically the therapy which is often called the target oriented therapy. You try to chop off that arm of immunity which is probably abnormal, rather than suppressing the global immune system, globally the immune system, by using drugs like cyclosporine, which is much more, it's not very broader, not as broad as systemic steroids, but yet it cannot be called as targeted therapy. Whereas we have the older biologics like alefas, probably the first biologic to be discovered for the therapy in psoriasis. Efalizumab was another old this thing, but no more available. It's FDA has closed its chapter. Efalizumab once again has become it's a history because of the serious adverse effect known as the PM, the multifocal leukoencephalopathy that efalizumab was capable of producing. And then we have the newer drugs like Remicade and adalimumab. Remicade is infliximab, etanercept, adalimumab. These are used and probably considered as perhaps the therapies which can give the best of the quality of life when it comes to the best of the therapeutic results. So now, what is the goal of therapy in psoriasis? So this is not by any standard textbook. This is in my own words, to provide a long-lasting remission. We don't look at cure. If somebody is offering cure, it is not an allopath. Never, no allopath who knows what is psoriasis would ever think about providing a cure. We can only expect a lasting remission. And such therapy should be devoid of major adverse effects. What is major adverse effect? The one which can damage the organ system. The major adverse effects are those which can cause permanent damage to the organ systems like hepatic, renal, or other organ systems. And it should be cost effective, because psoriasis does not choose only the rich. It can choose anybody. It could be feasible in day-to-day practice. Let me give you an example of a therapy like infliximab, perhaps one of the best drugs, but it has to be given through IV infusion. It's not easy to be given in a day-to-day practice, but still, it's one of the effective drug. Let's not say it's not an important. This fresh thing, what I could mention here is to detect the fresh targets. What is meant by fresh targets? Just like we have these IL-17 as a target, TNF as a target, IL-17, IL-12, 27, 23 as a target, IL-26 as a target. Now we need to look for fresh targets, not necessarily the cytokines. It may be some other molecule. So you need to look for the targets so that you can hit those targets and try to make it even more narrower range of therapy. In other words, much more target-oriented therapy rather than a broad target like cyclosporine or other drugs. So that is the goal of a research. And when you are able to provide some amount of all of these, like goal of therapies in therapy and research, then you would probably call such a therapy as novel therapy in psoriasis. When you say novel, it's not necessarily a more recent therapy. It need not be recent therapy. It can even be an old therapy which has some of these ingredients. So when I look at the dictionary of novel, what are the meanings I come across are these are the meaning. It could also mean unconventional. Unconventional means something which we don't use it regularly, but it could be ventured and it could be effective, or it could mean ultra modern, or it could mean futuristic. So all these are fairly relevant when we talk the word novel. So what are the unconventional therapy? I just happened to do some research going through, and I could see some of these which are used extensively in various parts of the world, and they have found some amount of evidence as an effective drug in psoriasis. For example, curcumin. Curcumin is our own haldi, and it's patented elsewhere, surprisingly, and it's being sold even in India. Indigo naturals is yet another drug. Now we have some of the very unconventional therapy. You can call it as conventional if you're a fan of meditation. It can be called as unconventional if you are a very strict modern medicine man. So meditation and acupuncture. Meditation and acupuncture has also some amount of evidence for psoriasis. And we have these ultra-modern therapies like TNF-alpha inhibitors, like etanercept, adalimumab, and IL-17, IL-12, 23 inhibitors, IL-17 inhibitor like we have the secukinumab and brodalumab, or IL-12, 23 inhibitors like and PDE4, the smaller molecules which we all talk about now. Of late, it's introduced in India. So these are the ultra-modern therapies. We have been using them. Let's not say they're absolutely new to us. We all have been using. I'm sure many of us are using at least some of these drugs. And finally, what is futuristic? Futuristic is something probably it is available elsewhere in the world, but we are yet to explore them, or they are available, but they are not extrapolated in psoriasis. That's also possible. So, for example, JAK inhibitors, tofacitinib. It's available in India. It's available abroad, but it's not approved in psoriasis. But it has been explored in psoriasis and found effective. It is awaiting probably the nod from FDA and other agencies for being used in psoriasis. Or drugs like newer biologics, like IL-23 P19 subunit inhibitors, they can be considered futuristic drugs like golimumab. Then IL-26 inhibitor, much more target oriented, so it's much more specific in its target, and certain other drugs which can also be called as novel. So this is what I consider as the futuristic therapy or the novel therapy in broader sense. So these are the ones which we need to keep in mind. I cannot cover all of them, but I would probably consider some of them. Probably it's good going through some of the drugs so that we can finally, the idea is to implement them in practice. If we are already using it, well and good. If we are not implementing in our practice, it is worth a try. Now, this is one of them. You all know what is curcumin. It is our own haldi. It's a purified version, is rich in polyphenols. Polyphenols are lipophilic polyphenol. Polyphenols are the very strong antioxidants, and they are available in a number of herbal remedies. It's an ingredient in many herbal products, but one of the richest sources is the curcumin. Curcumin is an orange yellow colored substance. You all know it's extracted from the rhizomes of the curcuma longa. Rhizomes means the modified stem of the plant. These are the various effects, biological effects it could have. And what is relevant in psoriasis is everything, almost everything. Anti-proliferative. Psoriasis is an anti-proliferative. It's a drug where we need anti-proliferative effect. Antioxidant, because we all know that there's oxidative stress exists in psoriasis, and immunomodulatory effect is something which we look forward. Anti-inflammatory psoriasis is that this is not just the cutaneous inflammation and even systemic inflammation with a number of systemic manifestations, including arthritis, the best known. Anti-neoplastic, probably it's not a neoplastic condition. It's not a neoplastic condition. It does not qualify to be neoplastic. But if you see the disease as such, it's a disease where there is an extreme high degree of proliferation, like exactly what happens in neoplasia. Only thing is we don't have a dysplasia here to be called as neoplastic, or it does not metastasize. Otherwise, it probably has all those characters of a malignancy. And even clinically, it may look like cutaneous T-cell lymphomycosis fungoides, wherein the lesions, the plaques of psoriasis can resemble. So for all means, it's something like a neoplasia, but it's not true neoplasia. And inhibition of lipogenesis, it's an anti-obesogenic property also it has. And we all know psoriasis it's almost explored and found that it probably is a component of metabolic syndrome. by means, what it means by metabolic syndrome. It can increase the chance of obesity, and obesity can increase the chance of severe psoriasis, both either way. And all of these can increase the chances of coronary artery disease. So that's what metabolic syndrome means. So curcumin, if it is used, perhaps it has got. If you believe that the drug works, it's a worth drug trying in as an unconventional therapy, but definitely not as a first-line therapy. But it can be used as an adjuvant to your standard therapy. So it has been found in vitro studies that the potassium channels expressed in T cells are inhibited by curcumin. And also in animal model studies, it reduces the inflammatory response of many of the cytokines like TNF alpha and IL-12, IL-23, which we know that are involved in psoriasis. And as I mentioned, although this haldi belongs to us, this is the name. Maraiva is the approved version of the curcumin, and it's available worldwide, and it has also found to downregulate IL-22, yet another key molecule in the pathogenesis of psoriasis. So it's a drug available in various forms. They are available in prescription form. They're also used. Sometimes some of the companies come and speak to us, but it's not aggressively promoted to dermatologists, but it's available easily in the form of capsules. It's available in drops. It's also available in various other forms. The other day, somebody introduced me curcumin lozenges for the cold. It was very, very tasty and a good product. I felt, maybe worth a try in psoriasis. It's one drug which may be worth it. I have no conflict of interest here, but I thought, it's worth when we are looking for a therapy, an unconventional therapy, in addition to what we are using. It could be cyclosporine, it could be, if the cost doesn't matter for the patient, often it's worth venturing into curcumin. It's one thing. Its a dosage can vary in condition, and since it's more like it's a herb, I don't think there is any adverse effect. I believe so, but of course we need to do clinical studies to say that there is no adverse effect. We cannot say that for sure. Now I will come to our conventional therapies. What are the current therapies that we practice? And I'm not talking about the old age therapies. I'm talking more about the therapies which are what I feel is which are of late we are using some of the drugs. So now I'll get into something which even I don't like. I'm sure you also don't like a picture like this. You can see a lot of arrows and a lot of figures, a lot of receptors, and there's outside the cell, inside the cytokine, and the nucleus. We have here nucleus. This is what is this color called? This is called peach color. So this is peach color thing is a cytoplasm, and what is this color? Whatever color it is. So it is the nucleus, and probably a light yellow or a creamish color is the outside the cell. So we have these various signals and receptors involved in the pathogenesis of psoriasis, and this is a typical model with which we learn the drugs. Here I have two drugs. You can see here. Sure, this is cyclosporine and tacrolimus. These are relatively newer drugs to us. Tacrolimus we don't use much in psoriasis. We don't use it in psoriasis at all. In fact, if at all, we use it in topical form on the facial lesions of psoriasis. Cyclosporine is a drug which we use in psoriasis, at least as a crisis burst drug we use it. How it works? All these drugs, both this tacrolimus, cyclosporine, and many other drugs, which all work by combining to something called immunophilins. We have this immunophilin, which is the cyclophilin for cyclosporine, and FKBP, that is FK506 binding protein, that is FKBP for tacrolimus. And both these immunophilins, then suddenly they become activated forms, and then they combine, they interact with the calcineurin. What's calcineurin? It's a calcium dependent phosphatase. What it does, the calcineurin activates what is called the nuclear factor of activated T cell. As you can see here, it's a phosphorylated molecule. It causes dephosphorylation, calcineurin, and once it gets dephosphorylation, it becomes an active nuclear factor of activated T cells, and that can get into the nucleus. Here you can see it's getting into the nucleus, and there it associates with various genes. In other words, the DNA, it interacts with the DNA, encoding these certain cytokines, like IL-2 is the most important one. So this is how it works. So immunophilins are required for tacrolimus as well as cyclophilin to act. And once they combine with the these immunophilins, then obviously they interact with the calcineurin, and calcineurin is suppressed by these molecules. So it's a calcium dependent phosphatase is suppressed, which keeps this NFATC, that is nuclear factor of activated T cells, in inactive form by preventing dephosphorylation. And once it stops here IL-2, now the next molecule which I need to tell you a little bit is over here. This is sirolimus. Now sirolimus work starts with IL-2. So it starts from IL-2 outside, and it inhibits what is called the mTOR. So mTOR pathway is inhibited by sirolimus, and mTOR pathway, it suppresses once the IL-2 combines with its IL-2 receptors, then finally this IL-2 has to act through this mTOR pathway, and this mTOR is inhibited by sirolimus. So we need to understand this, how it's connected. On one end, it prevents the production of IL-2, these two, whereas after production of IL-2, after it combines with the receptor IL-2 receptor, and finally it has to exhibit its action through mTOR pathway, and this mTOR is suppressed by sirolimus. Sirolimus is not a drug which we commonly use it, but it can be explored in psoriasis. I'll come to it. So then this is, once again, I'm quickly going through this. mTOR can do translation activity. It can have DNA synthesis, protein synthesis. You can see that all these means nothing but psoriasis. There is a protein synthesis, there is a DNA synthesis, and that's why this drug can be useful in psoriasis as well. So these are the few drugs I just mentioned about cyclosporin. When it comes to cyclosporin psoriasis, the first indication we have used, I have used in atopic dermatitis, I have used in urticaria. Very one case, I think, lichen planus, not much. Pyoderma gangrenosum, we have explored it, and bullous and connective tissue, we have not explored, but connective tissue disease, it can be an adjuvant as a steroid sparing drug also, it can be used. And tacrolimus, we don't use much in psoriasis, but as a topical form in the facial psoriasis, probably this is the best drug, tacrolimus, because we have an issue with the steroid on facial lesions of psoriasis, which generally occurs in children. And also we have an issue of using calcium, the vitamin D analogs on the face, because they can have an increased absorption and can disturb the calcium metabolism. And also in children, we prefer to avoid because its absorption is higher, wherein the tacrolimus happens to be a handy drug to treat the psoriasis of the face. Can we use it in systemic form? Well, it's not explored. I understand it's not explored. Not that it's not explored at all. I'll share my very little experience with systemic tacrolimus with psoriasis in the next one or two slides. And finally, as I mentioned, sirolimus, psoriasis is the last indication, but it can be used as an anti-angiogenesis drug in angiofibroma, Kaposi sarcoma, Muir-Torre syndrome, and certain other conditions. Let me tell you this very quick anecdote. As you can see here, this was a case of psoriasis. Why we used tacrolimus is an interesting story. This patient happens to be a case of nephrotic syndrome, adult nephrotic syndrome, rare, but it was a case of nephrotic. There was some issue in using steroids, and I was also not very particular. When I talked to nephrologist, he mentioned that let's avoid steroid. I told them I don't want to induce this plaque type of psoriasis into a pustular psoriasis, especially when we try to withdraw the steroids. So we discussed, and tacrolimus is one of the drugs which has got a strong evidence for nephrotic syndrome. And my thinking brain thought that let us not give a topical steroid in this patient because he's on tacrolimus. We just gave emollient, and you believe me, in 3 weeks this is what we got. When we used oral tacrolimus, the dose was about, if I'm correct, 0.1 milligram per kg body weight, and this is how the results was. So it can be a drug as good as cyclosporin. This is almost a result of cyclosporin, what I have seen, and yet another picture of the same patient. But when we continued, once again he started developing a little bit of lesions here and there. This is at 3 weeks, and again later on, which could be managed with some topical therapy. So I was good that I don't have to use tacrolimus. It was used by nephrologists, but I could also get a good remission for psoriasis. This is something. This is one of the cases. This is also accepted for publication in an international journal with yet to be published. So this is something which I learned from tacrolimus. Probably I am confident to use tacrolimus in this thing as an off-label indication. Obviously, it's not a regular drug. When something else fails, probably it's worth trying this. Now, what is ultra-modern therapy? Now, JAK inhibitors. Now, JAK inhibitors are very important to, it can be an extremely good weapon in dermatological condition, not just in psoriasis, because it has got a beautiful communication all through the surfaces, in the sense, outside the cell, inside the cytoplasm nucleus. It is one molecule which can connect all the three places, and that's how it can work. And that is why it is called, Janus kinase. I'll tell you why it is called Janus kinase. This is the reason. So Janus kinase, you can see here. This is the Roman god Janus. If you have been to Milan recently in the last year, July, for the World Congress of Dermatology, if you have visited the Jerusalem Museum, this is where this is found. The god Janus, the Roman god during Roman civilization. He is supposed to be a powerful god who can communicate. He communicates with the time. He communicates with the outdoor to indoor, and he communicates with the life and the death. So he's a powerful god, and that could be the reason why this is called Janus kinase inhibitor. Janus, the word derived from the Roman god. So Janus kinase inhibitors. So it also involves what is called the STAT pathway. So STAT pathway involves actually 4 proteins: STAT1, STAT2, STAT3, and the 4th one is the tyrosine kinase protein, which is included in the STAT group. Sorry, the STAT has got 7 proteins and JAK has got 4. So Janus kinase, JAK1, JAK2, JAK3, and one of the tyrosine kinase, because tyrosine kinase and the JAK are very closely related to each other. One is an extracellular domain and the other one is an intracellular domain, very closely related, which can interact with the multiple cytokines, and multiple cytokines can exert their action through this. How they exert? The STAT proteins are converted into an activated STAT protein. What is an activated STAT protein? If you remember in the calcium in the calcineurin pathway, where the dephosphorylation of the if you can see here quickly, so if you can see here, dephosphorylation was of the NF-A2C was responsible for the activation of the molecule. But here we have a phosphorylation of the STAT molecule, which becomes activated, and it can get into the nucleus and interact with the genes or the DNA, and then produce certain proteins, because of which it can produce inflammation. And this JAK-STAT pathway is blocked by these Janus kinase inhibitors, JAK inhibitors. The best example for a JAK inhibitor is the tofacitinib. It's available in India, not explored in psoriasis much, but it is explored by many for alopecia areata, especially in alopecia universalis. Can also be a useful drug in psoriasis vitiligo. In psoriasis, it could get approved because it has got a fairly good amount of evidences to support its usage in psoriasis. And yet another JAK inhibitor is a ruxolitinib, which is available in topical form also. It is approved in polycythemia rubra vera and myelofibrosis, but in topical form, it has found to be useful in psoriasis. Another drug, oclacitinib, in atopic dermatitis, then baricitinib and pefficitinib in rheumatoid arthritis. But these are the 2 molecules of interest to dermatologists in psoriasis: tofacitinib and ruxolitinib. Now, tofacitinib and 5 to 10 milligram BD, it has got a very strong. This is it's a systematic review of 5,204 patients, and it has shown good efficacy and tolerability when it's used in psoriasis. And 1% ruxolitinib showed 40% reduction in PASI in 3 months when used in psoriasis. So JAK inhibitors are the next one which we are probably going to use in psoriasis. Now, then I was talking newer biologics. Now, these are the much more target-oriented biologics, because it targets only the subunit of the IL-23, the IL-23 P19 subunit. And this I consider as the futuristic biologic. And I also call it as a great biologic, because it can be used even in patients with inflammatory bowel disease, where we have IL-17 inhibitors. We have certain reservation. We cannot use them because it can worsen the inflammatory bowel disease like ulcerative colitis, and it can also have a risk of candida infection, because IL-17 is one of the very important defense against the surface infections like candida. So IL-17 inhibition can produce nasopharyngitis and candida infection, whereas that is almost nil with not almost, it's nil, because it only targets the subunit, the P19. Why I call them as great? Because I remember this is how guselkumab, risankizumab, and tildrakizumab, how I remember is great, GREAT. So great biologics, the guselkumab, We have not explored them, but perhaps it's going to be explored, and maybe it has got a wonderful potential to be the top molecules when it comes to target-oriented therapies in psoriasis. And they have got, more importantly, excellent dosage schedule. That is once a month. And sometimes probably, I'm not sure exactly, some of them even as late as once in 3 months. So they have got a wonderful dosage schedule. What more you look for in a patient of psoriasis? Give an injection once in 3 months. Keep him under remission. What more we can ask for? This is the amount of I mean, maybe showing a very a beautiful face, but we really don't know unless we use them. We don't know how good they are. Then next is IL-27 inhibitors. It's a TH17. This is also much more target oriented. So it has been found to be effective. It could also be a future biologic with much more narrower range of target. And when I talk about monoclonal antibodies, I just thought we all talk about monoclonal. How are these monoclonal antibodies are produced, which we need to know. We have several types of monoclonal antibodies. We have chimeric monoclonal antibodies. That means it comes from these. Then we have human, no involvement. Then humanized. That means one part is a chimeric and other part comes from the human. For example, a myelin. This is an example for a humanized, which are called as, for example, adalimumab. Mumab means it's a humanized. Whereas infliximab, ximab means usually it's from a ximab is for the chimeric. And so that is how the nomenclature of a monoclonal antibodies. They all are produced by what is called a hybridoma technique. And this hybridoma technique synthesizes these monoclonal. I will not go into depth monoclonal antibodies. And this is one of the ways of targeting. Now, do we have other ways of targeting? Let us explore what next after monoclonal antibodies or fusion proteins. We have something more to psoriasis, which is exciting and probably it's going to happen. So promising therapeutic strategies now. What is there in research for psoriasis? Let us learn a bit about it. Now, what are the various therapeutic strategies in future we probably could think about is interference with the cell signaling pathway. So for example, one of them is a JAK-STAT inhibiting pathway, something like a cell signaling pathway. Similarly, there may be many more cell signaling pathway wherein we can interfere and bring relief to psoriasis patients. Inhibition or elimination of activated T lymphocytes itself. We have the B lymphocyte eliminating biologic, for example, the rituximab, which can eliminate B cells from the peripheral blood. Similarly, do we have such biologic with which we can eliminate T cells for a while and induce a wonderful relief? Of course, nothing is impossible, but we need to look about their adverse effects also, obviously. Then inhibition of leukocyte extravasation and angiogenesis. We probably can target at a place where psoriasis happens. So it can be also a psoriasis therapeutic strategy where exactly psoriasis happens. That means the cutaneous lesion. And finally, we can also look for right into the base of the psoriasis. What is the base of the psoriasis? What is the numerator of psoriasis as such in the pathogenesis is the genetic. The genetically predisposed individual with the denominators of various environmental factors finally results in psoriasis. So let's understand, unless somebody has a genetic predisposition, he will never get psoriasis. And it may be topped up by other denominators, like we know many things. It could be drugs, it could be infection, it could be some metabolic factor, it could be pregnancy, it could be anything. So various environmental factors, known or unknown, which add up and produce a psoriasis. Can we attack the base of the psoriasis? Yes, it's possible. So new psoriasis susceptibility genes should be detected, and can we interfere with the gene? Either can we upregulate a gene which is preventing psoriasis happening? It's possible. It's possible because there are alleles which are helpful alleles which can prevent psoriasis happening. At the same time, there are alleles which can promote psoriasis happening. It's a polygenic disease, psoriasis. There is not one gene, there are multiple genes. The interaction between these multiple genes which are promoting or preventing psoriasis happening, and this interaction between each other finally decides whether phenotypically a person becomes psoriasis, although he is genotypically psoriasis. So phenotypically to become psoriasis, there has to be interaction between genes, and these genes also interact with the environmental factors, and that is how finally psoriasis happens. That's how we can learn psoriasis. This is something very, very exciting to me when I look at the promising therapeutic strategy. So now let us understand a little more about genome. What is genome? Genome is nothing but a mass of DNA. Now what DNA does? DNA produces RNA by what is called transcription. Now the study of transcription is called transcriptome. Transcriptomic is the study of understanding how RNA happens on a strand of DNA, and then RNA makes the proteins, and we understand proteomics. That means a number of proteins are produced because of the interaction of these genomes. That means interaction of DNA, the interaction of the genes with each other, which is responsible for psoriasis. It produces a number of proteins. Some of them may be preventing psoriasis happening, some of them may be promoting psoriasis happening. So that is why it's called, when we study these proteins which are responsible for psoriasis, it's called proteome. And the subject that deals with studying all the proteins interacting with certain disease condition, could it be malignancy, it could be diabetes, it could be psoriasis, we call it as proteomics. And further next, so much more smaller molecules are produced like sugars, nucleotide, as a result of these proteins. Finally, the post-translational modification and then combined with sugar, and they are called metabolites. And studying these metabolites which interacts with the disease process is called metabolomic. Now, the most exciting among them and highly studied on psoriasis is proteomics in psoriasis. So omics sciences is developed of late. It's been developed for more than 1 decade. But are we talking about something which is happening elsewhere in some corner? No. The study on omics sciences is something which is exciting and expanding. And the various aspects of genomics is studied, like functional genomics, comparative, structural. I'm not going into detail, but proteomics is something which is very exciting because we have a proteomic center in my institute. We have a proteomic center running for the last 5 to 6 years, and I have tried proteomics in psoriasis, and that's something a little bit I would like to share with you because it can be a promising futuristic therapy in psoriasis. So what does it mean? The structure and function of the proteins are studied in proteomics, and proteomics also deals with a particular protein may be produced in a particular disease condition, and such a protein may be a diagnostic marker or it can be a therapeutic target. That is what is finally proteomics means to me. So you understand the dynamics. That means you understand how that protein has a significance in psoriasis. It could be a diagnostic marker. For example, if we can diagnose somebody who's going to get psoriasis or not, or we diagnose a psoriasis by proteomics. And then we have what is called metabolomics. I'll not talk about it because it's beyond the scope of today's lecture. So in proteomic psoriasis, the novel mechanism of new hypothesis for the pathogenesis of psoriasis can be made. And this is something which is quite possible and looks like feasible. And in near future, at least 10 to 15 papers on proteomic in psoriasis worldwide. Then biomarker discovery, and in the diagnostic and prognostics, that also I just explained, we can have certain markers, protein markers, which can help in diagnosing psoriasis, early diagnosis. And finally, proteomic profiling for monitoring treatment efficacy and drug-induced toxicities. In addition, I would also consider proteomics can also be a therapeutic target in future in psoriasis. Now, this is a little bit experience we have. We have been doing this study for the last 2-3 years. And what you see in the background is the machine, which is called OrbitTrap. OrbitTrap is one of the highest end machine for proteomics. And what does this OrbitTrap does? OrbitTrap traps the proteins. I feed serum or a skin tissue into this machine. It detects millions of protein which is there in that. Even the smallest of the smallest amount in nanogram or picogram of proteins it can detect. That's the amount of sensitivity that this machine has got. OrbitTrap. We have another machine called QTrap, which is for the metabolomic study. So this is our study team, and Dr. Keshav Prasad, who is the director of this research institute of our university, and so she's my junior research fellow who is doing PhD under me. So we have done about 45 patients, and we have done, but currently we completed discovery phase. Now 10 patients. We have detected 220 proteins, although we detected plenty of them. But what is relevant to psoriasis were about 220 proteins. Then once again, we shortlisted another 15 of them, which we thought it was biologically active protein, and they have a high relevance in psoriasis. And these proteins could be one of them or two of them could be a marker for the diagnosis, prognostication, and who knows, it can be one of the therapeutic target. And we have already applied for this patent, and because we have discovered these molecules. And at the same time, we also did yet another study. It is yet another place where we have molecular biology center. We also did this study on IL-17, TNF, and our Indian biologic, that is IL-6 inhibitor. You must be knowing about the Indian biologic, the itolizumab. We tried these gene expression in Indian patients with psoriasis, and we found gene expression was almost same as it is in the Western, because we don't have a lot of gene expression studies, because psoriasis in India may not be the same as psoriasis in US or UK. So because US, UK, the drugs like TNF alphas and all are if working, that doesn't mean Indian subset of patients they should be working. So we tried this gene expression studies, and we also found that these are all relevant molecules. There was a high gene expression for IL-17, TNF, and IL-6 in psoriasis patients as compared to the control. So that means these molecules are highly relevant for that. That means, certain aspects in psoriasis, wherever it is, it's the same. So with this, I think I have given some amount of brainstorming to some of the recent development in psoriasis therapeutics and various other aspects, and also I have revised some of the ultra modern therapies, and also I thought what is conventional. Only one molecule I explored was curcumin, perhaps worth trying in psoriasis. So what I feel, therapeutic armamentarium is expanding psoriasis. So better understanding of the pathogenesis has been possible, especially after the proteomics have been discovered. Proteomics studies have been
Please do not talk in between. Mute your audio.
Yeah, that's how the better understanding of the pathogenesis has been feasible with the discovery of various aspects, including that what I just explored, that is proteomic, and novel target oriented and cost effective and ease of use is what we look for when it comes to therapy in psoriasis. So in the last 40 minutes, I think I've done a little bit of justice to a privilege which is given to me being a part of PGNAR. Thank you once again, the team PGNAR, for making me here. Thank you very much. And if there are some questions, probably I would take it. Right.
Thank you very much. Thanks a lot, Dr. Manjunath. It was really.
Thank you, Mathur sir. Thank you, Mathur sir.
Thanks a lot.
Mathur sir.
Yes, how are you?
May I say a few words?
Sure.
Because Manju has finished in very much 40 minutes. We have 20 minutes. We will take a lot of questions. Manju is somebody is very close to my heart, very closest friend of mine.
Brother.
Great.
And you know how we became friends? We used to attend exams for post-graduation after our UG.
All right.
We studied in different colleges. Colleges we studied.
Same batch. And maybe we have met around 25 times attending exams for PG, AIMS, PGI, JIPMAR, Karnataka, All India. And by looking at each other, finally I spoke to him, and then we became friends. And he is very close to my heart. Very genuine human being, very hardcore academician. He will never do anything wrong consciously, knowingly. And we have great respect, mutual respect, and trust to each other. And we have a lot of people like that with us. Thank you, Manju. The moment I saw, I thought I should listen to you. And it was very inspiring. It's not easy to research so much, get into all these things, and with evidence. Okay, thank you so much.
Yeah, thank you, Dr. Reddy. And I also congratulate for your wonderful lecture on surgery. I have listened to it several times in various places.
Mine is always a practical thing.
Yeah.
But to be an academician like this is difficult. Mine is easier. It comes from skills and practicality. But to be a academician, teacher, and to be a genuine person is very difficult.
Thank you so much for your
Dr. Mathur.
Yes.
I think video has been discontinued from your side.
Sorry?
The video has been discontinued.
All right.
From the...
No. You can open it. It was being let me. All right. Let me.
You cannot open up.
No, I cannot.
No. Now you can open it, please. Even Maniyar sir is also.
Yes, sir.
Yes.
Sir, Dr. Mathur.
Please open it, sir. Open it. Now you can open it, please.
Yes, fine. Great.
We were missing you. We were missing you last 2 or 3 meetings.
Yeah, I know. I'm always there. So I want to ask you, Manjunath. Manjunath, since you are in a teaching institute,
yes, sir,
and you said you are using curcumin capsules, have you done a comparative study of using curcumin capsules in some patients and some patients with only our traditional method? So you can say that curcumin is going to be a better molecule in future or something like that.
Yeah, I have not done a study. I have used in few patients, sir, but as I mentioned, it has only been as an adjuvant therapy. I really cannot say at this moment to what extent it has contributed in the therapeutic outcome of psoriasis. Very difficult to tell because I have not used it and I have not ventured. Probably I would like to try in some patients, probably doing some blinded studies. Only then it's possible to say it works. And thank you, Niranjan sir. Niranjan sir is one of the academicians. He will ask such questions which has got high relevance in practice. And Niranjan sir is basically a Kannadiga. He's a Kannadiga somehow settled in Maharashtra. Whenever I see him, I catch him and I love to talk to him on this. Thank you, sir.
Manju,
Yes.
I had written in the chart that most of these natural products, we don't know the strength, we don't know the exact, the way they work. But nowadays, because of this corona, everybody is using the concoctions, mixtures with haldi.
Sure. Yeah. Plenty of things.
But the problem is, they are also therapeutic molecules.
Yes, they are.
We do not know how potent they are.
Obviously.
What their total therapeutic, because any natural product you take, it is not one molecule. There may be multiple molecules which act in different ways. That is so I think we should be open-minded to explore and design studies and bring in like that.
Yeah, but when it comes to curcumin, it is a product which has been studied very well because its dosage is defined with not necessarily for psoriasis, for other conditions, certain other conditions as an antioxidant, as a adjuvant in certain therapies. Its international brand is Meriva. It has got the patent. Meriva has got the patent, and they probably had patent. Now it must be off patent. Its dosage is 500 milligram. It's available in 500. It can be given BD or
What I
TID.
mean to say is that we can titrate the dose equivalent of haldi using in a crude form, equivalent to 500 milligrams.
Yes, it's possible.
Know the cost.
Yeah.
Dr. Manjunath,
Yes, sir.
can I speak to you, Manjunath?
Yes, sir. Yes, Janak, sir. Yes, sir.
Yeah. Sir, I just want to talk to you that there are different varieties of psoriasis. You see a patient with a pustular psoriasis of different type.
Yes,
Then you see erythrodermic psoriasis. The treatment modality will not be same. It will be different.
Yeah.
I wish you could have enlightened there because your talk was very complicated. I had a very poor digestion of very complex. I think as a clinician, I would like to know what will be the drug of choice, first drug of choice for erythrodermic psoriasis or a pustular psoriasis. What is the place of apremilast? I mean, to be honest with you, I'm very frank with you, with 48 years of my career in dermatology.
So your question is very relevant. But
No clarification.
Yes, sir. Thank you for the question, sir. It's a good question, wonderful question. And yes, my question, because my topic was such, the topic I have given is futuristic therapy in psoriasis. That's why I have not covered much of the basic therapeutic armament. As you mentioned, in erythrodermic psoriasis, perhaps the best drug I would still consider is the gold standard is, to me, it is methotrexate. And when it comes to pustular psoriasis, it is acitretin. I would still consider these are the gold standard drugs, and they almost always they have worked and they have worked it. In some patients with the erythrodermic psoriasis, I have used cyclosporine also. Even that works, especially as a crisis burst. I don't use it for very long, except in few patients where they don't respond to anything else. Such patients only have used cyclosporine for long. But by and large, cyclosporine given as a crisis burst, maybe about 2 weeks up to 6 weeks. It works very well. It can settle the erythroderma, but methotrexate almost always work. I prefer to use it in a subcutaneous form when I use it in an erythrodermic patient. So
according to you, methotrexate is not of value? You don't seem to be giving importance to methotrexate?
It is the gold standard, sir. It is the gold standard. Methotrexate is the gold standard drug in psoriasis, systemic therapy. There is no doubt, no dispute about it. Whatever new drug we talk is always compared with the methotrexate to say it is as good as methotrexate or not. That's it. Methotrexate.
Not only that, I agree with him. 90% of our psoriatic patients in Indian present situation, we can treat.
The last question is, do you know what is the interaction between HIV and psoriasis? There are a lot of patients present as the psoriasiform rashes. They look like an extensive psoriasis, and eventually it's a manifestation of HIV. Are you aware about this?
Yes, sir, definitely. HIV and psoriasis. Psoriasis is one of the, perhaps the second most common papillosquamous disease occurring
Yes,
in
correct.
condition with HIV. First being seborrheic dermatitis.
That
So
means,
psoriasis can HIV, for the first time the patient with psoriasis can manifest in an HIV patient.
Yes.
HIV can modify the psoriasis in usually towards the bad end of the thing. It can produce erythrodermic and pustular psoriasis. We have had hell a lot of trouble with the HIV patient with psoriasis. Not easy to manage because the only drug which you are allowed, if you are a very strict academician and very religious follower of the textbooks, then we cannot use methotrexate because we know it can deplete T cell and HIV. As such, the patients are depleted with T cells. And really, it's this thing. Only drug which can be allowed is acitretin because it does not interfere with the immunological aspects of psoriasis. But
Sir, Janak sir, being a senior most person, you are for Manju.
Sir, one more thing. I see a lot of iris psoriasis. You start antiretroviral therapy. The man who never ever had a psoriasis, you start getting psoriatic iris.
Well, sir,
Yeah,
the question answer will be keep on continuing. Let me have the pleasure of presenting the virtual memento. Dr. Lalit,
Yes, sir.
please present a virtual memento after.
Sir, ये नया है.
So, first of all, let me congratulate Dr. Manjunath Shenoy for his very excellent talk as always. I love listening to his talks all the times, and today was no exception. So he gave us, pretty much food for thought today to peep into the novel therapeutic armamentarium to treat a complex disease like psoriasis. And it was wonderful talk, sir.
Thank you.
And our congratulations to you. And it is my privilege to present to you this memento, excellently designed by Dr. Dinesh Mathur, sir. And I will be happy if you kindly accept the.
Yes, sir. Thank you, sir. Thank you. Wonderful. It's very nice, and I have taken a screenshot of that. So that means I have accepted. Thank you so much, sir. Yes, sir. Yes, sir. Thank you, sir. Thank you for the memento. Thank you very much.
Now the question answer session will start. Dr. Lalit, can you see the chat box and continue it, please?
hello, Manjunath.
Yes, sir.
So since you had got a research team and then you are studying that proteomics, which is very interesting.
Yes,
are you doing it in a normal individuals? For example, maybe about 100 patients you do study this. After that, say so many patients going to get psoriasis in future.
Yes, sir. All our proteomic studies are controlled. There is always a control group which we have used. That means who are the normal patient, who are healthy individuals. So we always compare this. Proteomic is always comparative. We cannot because we have millions of trillions of proteins in the body. There are various, and it also detects the smaller molecules like polypeptides and the various proteins. The proteomic is like that. So it is possible to study, and in fact, proteomic mapping it's called as. For example, each organ produces certain amount of protein, certain type of protein. For example, brain has its own. The brain has been mapped now. Proteomic mapping of the brain has already been done, and it's a paper which is published in Nature journal. And one of our, I have shown his picture, Dr. Keshav Prasad, he is there with me in that one of the picture. He is one of the author for this paper. So they have done the proteomic mapping of the brain. Similarly, all organs can be mapped for protein. Which proteins are specific for this organ? So these are all the normal proteins for those. So when they come, they are excluded. We don't take them as disease proteins. The other proteins which are expressed in high amount as compared to control, they should be considered as the abnormal proteins when we are dealing with a disease-like situation. So that is how the proteomic works.
Manju sir,
yes,
do you normally put into the normal skin versus the psoriatic skin versus the other disease to find out the different profile of the different proteins, the normal skin and psoriatic skins?
Yes. Yeah, the problem with the skin proteomic is that, sir, the skin has got keratin and skin has got an abundant protein. It's not like serum. Serum is relatively easy because serum is studied well. We know the proteomic of normal proteomic, whereas skin is not studied well. That is why there is a problem with doing a skin, but it is done. There are papers on the skin proteomic as compared to the normal. But the problem is that the abundance of proteins like keratin, which is unwanted protein when it comes to the study. So there is a difficulty. There is, and also Yeah,
Can something be done to filter out those, known proteins
yes,
in the
yes,
skin?
yes, sir. There is definitely standard protocol is there how to you have to take out. For example, albumin in serum is an unwanted protein because it's an abundant protein. So abundant proteins have to be taken out. There is a definite method, and everything is nowadays everything you don't need to do. You just need to tell the computer do this and do that, and that computer eliminates automatically in that orbit trap machine and the Q trap machine. So they are all fed. They are all everything is happens in a digital world. You can just do that. It's possible. We need to know what are the proteins we don't want.
Which other diseases you are doing it? Which other conditions you are?
Yeah, I have taken it in psoriasis. Now that study is almost completed, sir. We are almost about to in a stage of we have sent for we are trying for a patent now. We are about to apply for patent because we have found some new molecules, new proteins. The next level is we are going to publish these findings, our findings. It's not a new paper. There are papers on psoriasis proteomics. Now in the center they are doing for many other diseases. For as far as my department is concerned, we are doing in psoriasis. We are also trying to explore. It is not started. It's too early. We are trying to explore the proteomic markers of the common prevailing fungus. Here we are not taking the human. We are taking the culture of Trichophyton rubrum, Trichophyton mentagrophyte. We are trying to look for the proteomic marker which can help in the diagnosis. So we have this conventional diagnosis through and then molecular biology. So if that particular fungal agent is capable of producing a particular protein, so that can also be discovered. And that is what is the machine is mass spectrometer. Mass spectrometer is capable of doing that. So we need to have the proteomic marker for the various dermatophytes. So with which also we can diagnose. We don't have the definite proteomic signatures for the dermatophyte. They are not published yet. As far as other fungus is concerned, there are Candida, probably various species there is. And you must have heard about a machine called MALDI-TOF, which is for the diagnosis of the various microorganisms. And MALDI-TOF runs in this mechanism, the mass spectrometer. The mass spectrometer which detects the protein. And this similarly, we are also trying to detect some of the proteins but it is too early. So it's too early to say, but we have to venture into it. I need to find a research scholar because I cannot do it because we have our routine work. Patient management is our strength. So we need to have a research fellows who are going to work on that, which means I need to take some PhD candidates to do that.
Dr. Arun Joshi is a very regular attendee. I do not know whether he's from Dubai. Is he here, Dr. Arun? Dr. Arun Joshi, is he here or is he left?
I think he's there, but he's
very much.
Yes. He is a person. Namaste.
Sir, it's a great series, sir. I am there from minute one, and I thoroughly enjoy. I'm gaining quite a bit. Dr. Lalit was 1 year senior to me in AIMS, so he has been a guru to me from that.
And you are in Dubai right now.
Kuwait.
Kuwait.
I'm in Kuwait.
Right. You ask some questions. Why not you ask?
No, Dr. Arun, it is our loss to Kuwait.
Sorry?
We have around 9 lakh Indians, sir, in Kuwait. So we are serving, besides the Kuwaiti community, we are serving Asians.
Kuwait.
Yeah.
You all command a lot of respect there, I am sure.
You had some comment or question. Would you like to speak yourself, please? And
this comment was about curcumins and bioactives. Right. I think, as Dr. Raghunath Reddy also said, there are a lot of basic research papers. Like these are now not the haldi as such or black pepper as such. There are these active ingredients, molecules have been identified, and now those are the preparations which are being available. Like in case of curcumin as capsules, 600 milligram and all. And sometimes they do have some side effects also, like if they are given in too much of dose, 600 milligram 3 times a day or something like that. For various diseases.
Everything in this. But otherwise, we are using curcumin and all these black pepper and everything from ages in the sense. And,
so what is needed is, I think, maybe to identify and make it more like an allopathic preparations, more quantified and more standardized. True. And they may benefit in our chronic diseases. That is the comment I wanted.
No, Dr. Arun Joshi, you said side effects. What side effects you have come across?
No, the side effects mentioned are like GI side effects, excessive taking, if there is excessive dose, diarrhea, loose motion, weight loss also. can happen. These are others are not very serious.
Anyway, that is
Mathur,
not
sir,
that
I
is a
had
major.
written that comment to Arun.
Yes.
Any natural product is a 100% product. If you have studied that, we do not know the exact therapeutic mechanism and as well as the side effect and adverse effects.
Correct,
That
correct.
is why he is making that comment that we should adopt this product, we should study and make them as a therapeutic product adaptable to allopathy. Because many times now we will come across a patient who has a lot of allergy. They are not taking any medicine. Now they are taking these decoctions which are made of natural products. And you know that natural products are medicinal products and they're more stronger medicines than the medicines what we have. And they have hundreds of molecules than what we have extracted from them. So natural products need not be safer. That's what you were trying to say. That
Dosage,
extract a particular molecule.
One question is there that if IL-17RA fails, what should be the next best biologic? Dr. Manjunath, can you take it?
Now let us not think IL-17 itself is the ultimate drug. Let's not take it that way. So IL-17 can fail. It can fail. So we always have so many molecules. See, why IL-17 somebody has given? Probably because the patient may be having certain issues with methotrexate, certain issue with cyclosporine, certain issue with the other systemic drug. That may be the reason. We have, in case we have to give a biologic, we can always get TNF alpha inhibitors. It's worth a try with TNF alpha inhibitors. Or one can also try with another IL-17 molecule like, of course, they're not easily available in India. What we get easily in India are TNF inhibitors like adalimumab and etanercept. Infliximab is available. Infliximab I'm not very fond of that drug. It's a
with IL-17, sir, may I say, when we use it in very severe erythrodermic or very active psoriasis, it gives wonderful results, but recurrence is a rule. Once you stop that, the disease will come back. But when it is really necessary to use it in a patient with psoriatic erythroderma or a psoriasis which is very active, not regressing due to various side effects of topical steroids or systemic steroids, it gives wonderful results, but always recurs after stopping the drug. But it has advantage. That is the fastest acting drug next to cyclosporine. Cyclosporine, Manju, is a crisis buster. Use the word, the bullet, called as a crisis buster. So IL-17 is a wonderful drug to bring the disease under control, but then you have to depend on some other drug, maybe methotrexate, maybe adalimumab or infliximab to maintain.
Well, thank you very much.
Thank you, Dinesh.
It was a very nice evening. See you on next Tuesday.
Thank you, sir. Very good, doctor.
Thank you.
Very good.
Thank you.
Bye bye everyone. Bye.
Thank you.
Lalit, bye.
Bye sir. Bye. Bye bye sir.